I figured I would do something different today, because really, as we only have about 6 weeks left in the term, and really, I think the focus needs to be a more. To me, it's more. Everything for me is more clinically oriented, like how we use these things vis-a-vis people, and really the relevance of nuclear medicine and related. What I mean, you use the term here because of the nature of the degree of nuclear medicine. I mean, collectively, for years, we called it advanced imaging. Because to go back, way back, historically speaking, so, so when I started, I got my doctorate in 1977. I know it's a long time ago. Don't start. It's all right. I'm already feeling my age. Okay. So I got my doctorate in 77. We had x-rays. Okay. We had some scans that I'm going to talk about today, but we had x-rays. The word MRI was not even in the lexicon at that point. The CTs were in their infancy because they're all computer assisted studies that are there. So we had some ideas about nuclear medicine, but it was basically variations of x-rays. So you took x-rays, and sometimes you added, for instance, you would take an x-ray and you'd squirt something in. If you want to see a joint, you would squirt what's called a radio opaque material, generally something that had iodine in it because it's a relatively heavy molecule, and the radiation wouldn't get through, and it would outline the joint, or it would outline, you insert it into the cerebrospinal fluid to look for, basically to determine whether or not a disc has slipped. So all of those procedures were by nature invasive. Okay. All those procedures by nature were risky, not the least, I mean, elementally because of an allergic response to any of the materials. So we've gone from that, and now there's limited invasive and non-invasive procedures, which I think are very interesting, because when I looked, I mean, that's why I just cooked this up for you. So I got to make sure I have the right, because I'm using my laptop. It's easier. So when we looked at this in the document, this was the topic for the du jour, late effects of radiation. And I mean, if you look at the textbook, there's nothing that dramatic or interesting about it. So, I mean, I have a presentation today that I'm going to sort of jump around and look at different procedures, different things that we use for them, the relevance of procedures, which I hope you find interesting. And then what I want to do is, if I do not complete some of that Thursday and present to you something of a case, just a case study, for example, okay, to show where the utilization of some of these are. It won't necessarily be, that was my other question that I had, because I mean, to me, late effects of radiation are just that, late effects of radiation. We can go over people who have been exposed to radiation and long-term problems and genetic problems, and certainly effects on the fetus and the embryo and in subsequent generations is certainly very, very relevant. I mean, those are all major areas, and I'm sure you're schooled in all of those, correct? That's the kind of information, that's the kind of thing that you focus on as you begin to be more clinically oriented. Do you have anything to do with MRIs? Okay. I mean, is that something that you would be, as part of your eventual license and professionally, be part of that process? Good. Good. I hate those things. Okay. Anybody had an MRI here? Oh, I am claustrophobic. I am past claustrophobic. I'm like, they got me into that thing, and I'm like, and so my wife's telling me, don't worry, it's not a big deal. I've had one. And, as soon as I get slid in that tube, the next thing I know, I'm screaming, let me out. I'm pushing the button. Let me out. Let me out. Let me out. Panicked. Totally panicked. And boy, did my wife yell at me for that. She had gone through it. I mean, they would have to sedate me and do everything. And then the distinction between, a lot of people will tell you, and I'm sure the technologies improve, is the distinction between the closed tube and the open MRI. And the open MRIs, at least at the time, were not considered to be as accurate when we were looking at those studies. So the science has evolved, as part of the computer age more than anything else. So I thought I would acquaint you with those and have you take a look at some of these things. So it's much easier with my limited graphic ability to design PowerPoints to borrow these from this what they call SlideShare, which we've used before, which I happen to like. So that's kind of where I'm heading with this. As soon as I find where I'm going, so I'll start with some of these and just begin to comment on the MRI is more relevant because the case study I want to do on Thursday involves MRI, and I have the actual MRIs and all of those things. You do the cross-sectional anatomy, correct? That's it. It's so hard. That's the most difficult thing that a lot of students have, is to be able to visualize things in that sense, to be able to imagine, think I'm here, or I'm here, or I'm here, and what you're going to see. It's not easy at all. It's very difficult to have, and we used to call them spatial relationships. It was the kind of thing that they used to test you on with, not necessarily IQ tests, but different kinds of testing and competency. You probably had this where they show you like a geometric figure here, and then they'll have like 4 figures at different angles, and you got to figure out which one matches. You know what I'm talking about? That kind of a thing. Yeah. Some people have a gift for it, some do not. And I was lucky because I was good at that, comparatively. Don't know why. It's all right. I have a vertical leap of a half an inch, so I don't have any athletic, and I have negligible musical skills whatsoever. My wife won't even let me sing. She goes, I don't want to hear it. You sound like the cat. So MRI, backstory. At Seton Hall University in South Orange, New Jersey, circa 1971, I had transferred there from Lehigh University, and where I was a chemistry major because I like chemistry, which is the degree I graduated in. We had a device called an MRI. It had nothing to do with MRI, that giant tube or anything like that. It was a device that fit into a small prep room. Let's say, you could fit 20 of them in here easily enough. So all it had was effectively a large console, because in those days, technology was huge. It wasn't small whatsoever. And it had something where you basically dissolved in specialized liquids. You dissolved a chemical, put it into this device, spun it around. The whole idea of magnetic resonance is to spin stuff around. And what it would do, it would excite the protons. And you'll see this in the presentation. The hydrogen ions they would do is called resonate. So they would be excited, and when they drop down, they would release certain amounts of energy that were associated with it. And that would translate to almost like a barcode, not even a barcode, but like different spikes. And we use that to analyze compounds in chemistry. So now, that technology is now being used in like 3 or 4. We have one here in the lab in the biology lab that does like 4 of those tests simultaneously. Just for instance, to look at the advances in technology over that roughly 50-year span. So they showed me how to work that, and I started doing it for all the other students. That was my first exposure to MRIs. It was 1971. And then simultaneously, computers began to develop. We had just to give you some reference from somebody who's no longer young. We don't want to use the old word. See, go ahead. I see what you're saying. I like that with the nuclear medicine on the shirts and on the. That's nice. I like that. Just saying, complimentary. And so what went on is we had, at that point in high school, we had a computer that was that, and we used the old key punch, which is effectively a typewriter that made little holes in cards that looked like Scantron cards, and you learned languages like Fortran and BASIC, long before the days of C++ and things like that were there. That moved on. We had at that same year, we had our first calculator. So I can open up, and you can open up your phone and get a calculator that's more advanced than that. this very instant. Our calculator, we had it chained to the wall because it was cost $500 and they were afraid somebody would steal it. So it gives you an idea of the technology. When we did technological analysis, I was very bright. So what I did was I found a very smart lab partner. I wasn't so good with this stuff, but she is brilliant. She later went on to get her PhD. She's deceased now. And she went and got her PhD in chemistry. And when we would do experiments, we would take the phone and put it into like a cradle, and little beeping sounds are what basically how we did it now. That gives you an idea of the distinction of technology. In practice, my first computer was an IBM, not an AT, but an XT, which is an 80-286 system that had a modem with 14.4, not megabytes, not terabytes, but kilobytes per second. And it was a dial-up system. Just to give you an idea. So you watch old movies, you might see that and hear those same tones, just to give you an idea. So this is what the technology has done. It's a radiology technique, but the beauty of MRI is this: you're not theoretically being exposed to it's non-invasive. So you're not sticking something into somebody, and you're not using ionizing radiation. We're using magnetism. And as far as we know, and I mean, that's an interesting thing that I was starting to research, we're not seeing any long-term effects at this point. And maybe the technology's been around for the last 30 to 40 years or so, something along those lines. That's another interesting story about that. So magnetism, radio waves, and a computer, and that's what you're basically doing, a computer image that allows you to visualize a structure that you're scanning in a series of planes. So you can do them. Did you guys, you did all that cross-sectional stuff. So you had things like sagittal, right? Ring a bell, sagittal plane, frontal plane. So when we look at these, and you probably have seen if you had a knee MRI, like a lot of people have, that's basically we call them slices. Trade. Years ago, you get this stack of very heavy X-rays. Now everything's tissue. You're able to look at it, and they look at those scans, and you look at the slices, and you look at the grid on the slices to see wherever it was, where the ligament tear was, where the bony defect was, something along those lines. So as you can see, not that long ago. I mean, to me, that I don't know that that's necessarily correct. That 1997, I mean, this is in India where this comes from. I can recall MRIs earlier than that were computer assisted. That was a whole big thing when my first wife wanted to get an MRI done. This was circa 1980. We had a consult in Houston. She had a very interesting condition that's hereditary called neurofibromatosis. In its worst, its next to worst presentation, it's the elephant man disease. It's a very, very famous condition. And because about 10% of those individuals have optic nerve gliomas, so they have tumors in the optic nerve that lead to blindness, they wanted to do an MRI. We went here and saw a very important neurologist, who's going to use the term, at UPMC way back 4 years ago. And he said, we only would do CT scans for that. Because he had an investment in the CT scanning place. It's a long story. So as you can see, think back then, and again, I would take issue with the time about how long potentially this, 5 hours to produce an image. So it gives you an idea. Now, you see the typical, this is an ultrasound device. So it's a little bit different. Again, that's also non-invasive by definition, and it's not ionizing radiation. And ultrasound is wonderful. Okay. It's been not so much because of it's made gender reveal parties so much more fun for a lot of individuals that are there. And I can recall my kids doing that type of thing. We didn't have that luxury, but more because it's been around for a long time. It's high frequency sound waves that travel very, very rapidly through skin and basically they bounce off of different soft tissues based on their density. So if it's water, it goes right through. If it's fat, more difficult. If it's bone, it bounces off directly. So you're able to then produce an image by the reverberation. So you have a transmitter and a pickup. This is obviously a more elaborate system for things like that. And inevitably they give you a timeline with these, which I'm not going to go through. And looking at and again, seeing at the source with this, but you can see the Nobel Prizes that were associated with the advancement of the technology. It has changed a bit today, but for the longest time, we felt that X-rays, particularly the computerized tomography, the CT scans, were more beneficial to look at bony abnormalities. That you got and this is the way I was taught, a better view of bone when you look for things in the soft tissue. Okay, soft tissue tumors, ligament tears, classically in the knee, and things like that. It would be more like the MRI. That has changed quite a bit with advancements in technologies. But these, as you can see, there's a lot of things. Now, what has developed over time is this ability of what they call the functional MRI, which allows you to look at blood supply because the magnetic scanning technique is able to distinguish between well-oxygenated blood and less well-oxygenated blood. So, and from that, they can generate this classic that you will see image that's associated with different colors, which makes it very easy to see. So a variety of these things that you can see that they list have all been, at least, and I think this was from about 2017. Big problem with the magnetism is if it's something that's magnetic and it's embedded, it will move it around. Okay, so you can see things like pacemaker. Typically, stainless steel is not affected. That is my understanding. I have in my gut from 2 operations stainless steel suture, so it's not. And that has every so often when I'll go through the airport and get scanned. They have to. I figure they're. I'm very cooperative. I don't want to be tossed in jail for that type of thing. They look for that. I don't know enough about cochlear implants. The big problem is metallic foreign bodies, or being foolish and bringing your credit card into that type of thing and ending up with dying. Okay, all of those types of things that are part of it. So that most of us are aware of it. The beauty is, and it's all about protons. So going back to your basic science training, you have neutrons. So a proton is basically a charged particle. We have an abundance of those in terms of hydrogen, because we got hydrogen ions everywhere. How do we make energy? The proton motive force. We're made of organic compounds. They have a ton of hydrogen. We've got hydrogen everywhere. And depending on how the hydrogen is arranged and what happens with magnetism, it spins and gets excited. Okay? So as you can see, it changed, and you'll see the illustration how it changes the alignment. And so the nuclei can be rotated using radio waves and oscillate, vibrate effectively. And as they begin to return, they release certain degrees of energy. That's sort of the easy, I think that's the easy way to describe it. And so but from this and using the coils, and I'll show you the apparatus, which I certainly wouldn't want to go into since I don't know a lot about it. But here you can see what they're talking about, a random arrangement versus an application of an arrangement. And again, trying to do this types of things. So what is involved is and most of you are familiar with this, various types of coils and things like that. And that's really what the device involves. Coils, very, very large magnets. It's very large. It has to be isolated. It has to be shielded to avoid the impact of that magnetism. It's like walking by with your credit card, and it's going on in the room next door. Conceivably, next time you go to the ATM, you're in trouble. That kind of thing. And it goes through, and again, this is way above my pay grade with regard to what happens with the magnets, but all of those types of things are the kinds of coils that they're showing you. So some of the stuff I'm just going through just to amplify the points that are there. No ionizing radiation. It can deal with items of varying thicknesses, which is what the human body is. You have very good ability for resolution of contrast. And a lot of this, and this is the beauty of it, is you can see it without having to inject contrast materials. So you're dealing with, and again, when you see the terms invasive versus non-invasive, again, non-invasive doesn't mean it might not, it couldn't cause a problem, which conceivably it could if a person wasn't screened properly. But what it certainly indicates, okay, is you're not having to inject something in them or administer something to them, which they could have an allergic or some other reaction to. So, and if you're sticking a needle into somebody, then you have to, now you have the risk of infection that's associated with it. So non-invasive things are good. So that's another area that I look at with regard to them. Yeah, costly metallic devices. I'm Captain Claustrophobic. Okay, you've got to be perfectly still, and it's not a whole lot different than taking an X-ray. We have, I mean, that's really the rate determining step is movement more than anything else. And so they're showing you the different machines, and here's the functional one. So it works by detecting changes in blood oxygenation and flow that occur in response to neural activity, which is very interesting. So you can view both anatomy and metabolic function. You can look at oxygen levels, different types of resolution, probably more advanced. And so you can see the difference. This is what's meant by a section. Those hollow areas are called ventricles. They're filled with cerebrospinal fluid. So immediately, you'll get different images based on it. And here you're looking at different availability of blood supply. So you can see the difference between what the MRI has, something different than a CT, which is really a series of X-rays done at different angles sequentially and then computer enhanced. Radiation exposure. Maybe the resolution depends on what you're looking at. I don't know that that's necessarily, I think that's more of a broad brush. Depending, again, if you're looking at bone, to me, it always had excellent diagnostic information. So again, bone played a role. Typically, you're doing, the slices are definitely transverse planes, cross sections with that. And yeah, it's quiet at least. But I've had CT scans done of my abdomen with contrast when they were, prior to me having gastrointestinal surgery, where they had to look to determine if my common bile duct was intact, because it really dictated what kind of surgery I was going to have to undergo. And I don't really care about the whole manufacturers and things like that. It's big business. As an aside, for those of you who have a business bent, okay, and I say this to you for young people on career paths, if you have a business bent and you present well and understand the technology a bit, sales are very, very lucrative. And that's something we're talking about departmentally, to try to come across with a science degrees that have incorporated business degrees, because there's a lot of opportunities. You might like dealing with patients, but if you find you don't, you might use your background elsewhere. That's why I always wish my daughter would have gone to school. Other than parties. Oh, come on. She only got arrested once. Just saying. Wait till you guys are moms and dads. Just wait. So there's not a whole lot left on this particular one. And you're welcome. Thank you very much. We'll get out. We'll escape from that somehow and move on. So I did that one. What we talk about a lot here, radionuclide imaging. Okay. So you're using what are called radiopharmaceuticals. The whole basis is what? The basis is being able to, and we use the term tag, or I did, whatever the terminology is appropriate for your field, you could use, and we would use particles, probably more so than anything else, something called technetium-99, correct? And what it does, it emits a reliable source of radiation that's not extraordinarily problematic, comparatively speaking, and you're able to attach that to a variety of different molecules to allow you to be able to visualize things, frequently because of blood flow or certain cellular types. I mean, if you wanted to paint it again with a fairly broad brush. So you can use, as it says here, for almost anywhere, depending on what you attach it to. And you can attach it and you go to the kidney. The one I'm very familiar with are bone scans. We did them all the time. And bone scans are interesting, and they'll probably talk about it a little bit because we always used to order things called triphasic bone scans. Term you're familiar with? No. You scan the person when it starts. You can scan the person 10 minutes after. They sit around in the hospital, or wherever you're doing this, or the unit where you're doing the study, and about 2 hours later. So you have a delayed image. And you can tell lots of different things. And they have some illustrations of those that are there. A friend of mine, when he was doing a lecture in front of a very large surgical conference, kind of called them, and they're somewhat non-specific unless you're looking for something specifically. He called them an anatomical thermometer because he just kind of showed you. I mean, it could be anything. It could be inflammation. It could be arthritis. And as you get older, everybody's got to say arthritis is part of it. So all of those types of things are really very interesting. So a molecule that can attach to a particular target organ, that's radioactively labeled. And they'll show you some of the ones that, again, the technetium-99, the iodine. I don't know what iodine they're using. This one is 123. I mean, which one is the most appropriate for that? Okay. Selectively absorbed by the particular organ, showing the function. Low radiotoxicity to give minimal radiation, critical organ. And obviously they're going to look at half-life and things like that. Again, that's more of the technical end of things. Okay. Have to be pure. They can't be apyrogenicity, meaning that, it's not going to, pyrogen would be something close to fever. And that's one of the big things. Whenever you get something that's not native to you injected, one of the first responses your body has for inflammation is fever. Unfortunately, over the years, I've had, you should probably be able to tell, entirely too many surgical procedures. So I've had about 50 units of other people's blood. So I've had maybe 20 to 30 different sets of transfusions, and they'll always give you at least 2, and sometimes very severe 3 units. I've had a couple of those. The thing they tell you to watch for, and I never had a transfusion reaction, was for fever, just as an aside. So it's not as easily looked at in that way. So take a look. Technetium-99, with a half-life about 6 hours, brain tumors, nice spelling on thyroid, skeletal system. I-131. Okay, iodine metabolism, liver, kidneys. This chromium, hematology, gold, liver brain diagnostics. Didn't know about that. Sounds expensive. And let's see, root, muscles, skin, bone. So whole body, genitals. So they're grouping them with regard to decreasing or due to decreasing or radiosensitivity. So bones would be the least radiosensitive, where bone marrow, as we learned about before, the lining of the small intestine, reproductive structures being more so that are there. They tell you about how to store them and things like that. Radioimmune assay is another utilization for these, where you're able to, again, tag things radiographically and get an ability to determine whether it's, again, that's more laboratory oriented. We used to do a lot of these RIA things in the early days for things like allergies and to be able to detect exposure to disease. It was sort of a way of trying to tag antibodies and see if someone had certain antibody levels. It was done a lot in the old days when syphilis, which is a sexually transmitted disease, was much more prevalent. That are there, and I will continue on. So they want to know how rapidly it clears and all of those things that are part of it. And they show you some of these the other information. Of course, the gamma camera is used now, and there's other types. Okay, scanning scintigraphy, if I'm pronouncing it correctly, and single photon emission tomography and 2-photon positron. So you're educated about PET scans as well, correct? Fascinating. That's another game changer. So here what they're looking at, method of visualization by moving over the body of the scintillation detector, etc. And the scintigraphy, which I'm sure you're doing more than anything else. The distinction of different kinds of lesions, where you look for hot spots and cold spots. Most of the time you look for hot spots, okay, with increased amounts of circulation or increased amounts of reproductive activity. But for instance, you probably know this already, the thyroid, you look for cold spots because the thyroid is normally very active. A tumor typically means it doesn't have the anticipated activity. So you're looking for cold spots. The other things that we look for a lot, particularly vis-a-vis bone, are the two types of tumors that we see when they spread to bone. They fall into two categories, blastic and lytic. Blastic is one that's more easily seen on a bone scan. It's increased activity. Lytic, it means punching holes. So the two most common cancers that we see that are glandular cancers that go to bone in people, okay, breast cancer, prostate cancer. Obviously, breast cancer, much more prevalent in women, prostate cancer only in men, you know, other than maybe an extreme, unusual hermaphroditic case. Breast cancer is lytic and prostate cancer is blastic. That's one of the, and those are the little clues that we look at to determine what the source of those problems are when you look at them radiographically. So, healthy liver, thyrotoxic adenoma, and this what happens to have a hot node rather than a cold node with that particular tumor that's there. This is when you're looking at a scan that reveals multiple lesions. So this, inevitably, this would be someone, this is not one you want to have anybody close to you or yourself get. They're not going to be around. We saw this with, and I didn't see the study, I read the report, of a man who didn't even realize, either he hid the fact that he was sick or didn't know it. In March, he brought the studies to us, to me, take a look at it at home. The family is very, very close to my wife. And 2 months later, it's gone. So here, it's a typical bone scan. So exactly what my guesses would be the late stage of the bone scan. And you look at the areas of remarkable increased uptake here in the knee, and you can see that it's there. And I mean, we haven't even talked a little bit about when they get into the MRI. Did they tell you about T1 and T2 weighted images? Is that ringing a bell? Anybody? T1's, think of this, T1 is mostly about solid stuff, T2, liquid. So it shows water levels, read that as swelling. Helps you work with things like that. And so what I'm doing is I'm going through some of the more, leaving the technical stuff out. I don't know enough about the single photon emission computed tomography. I honestly, it's interesting if we're looking at vascular disorders. That's always been a difficult spot. For instance, when you're trying for years, and it's a personal note. So my dad didn't survive heart surgery. My dad had an allergy to iodine. Remember in those days, they'd only had iodine to use. You would inject it in an artery, usually using the femoral artery as the entry point. Feed a catheter up to the heart and squirt an iodine labeled compound. And iodine, it was an X-ray test as opposed to a quote unquote nuclide scan type of thing. He was allergic to iodine, and they said, look, it's more important we find out what's going on with your heart, because that way they could tell which blood vessels were involved and which ones had to operate on. And, I mean, unfortunately, he didn't survive that, which is a whole other story when I talk about cardiac types of things that are there. And here's the wonderful PET scan. Okay. Ultra short lived radiopharmaceuticals emitting positrons. Okay. And they allow us to conclude the change rate of glucose. Okay. So the beauty of that is it is able to detect glucose is the only energy source in the brain. So when you see increased glucotic activity, you have an idea what normal is, and you look for areas that are increased or decreased. For years, we couldn't make a diagnosis of Alzheimer's, okay, other than post-mortem, when you would see characteristic changes in the brain. Now, you can actually monitor that vis-a-vis PET scan techniques, which is just fascinating because at least I don't know that it changes the outcome so much as it at least gives you an idea to track it more efficiently. And so let me buzz out of that and see where I'm going with that. That was the imaging. These are the different pharmaceutical agents. And this is very comparatively short. Thank you. So they're just giving you the idea of what makes an isotope radioactive, and that's an unstable nucleus. So rather than carbon, which is usually 612 or 613, when you get to 614, that's what we utilize for carbon dating, because it emits it relatively slowly, but we can track that with a mathematical formula. That's where carbon dating comes from. And so they're just looking at these different things that are part of it. But as you can see, then this ties into just in general effects, what can happen from radiation. Enzymes, which control all the functions in your body, denaturing proteins, the classic DNA, RNA, particularly DNA damage. When they talk about histamine-like substances, those are things that create allergy or allergic responses. And oftentimes we see that after, the skin, the hair, cataracts, leukemias and anemia. This is all affecting bone marrow, etc. And then obviously they take a look at something you're schooled in with regard to half-life and the different, I'm trying to get that so I don't have to have it advancing, that are there. Thank you very much, and you're continuing to advance. So you can see why technetium-99, relatively low toxicity. That's there. And then they look at the different kinds of half-life sources that are there, different ones that are part of it that you can utilize orally or injectably as various kinds of, and again, biological tracers that are there. So you can see the myriad of uses: lungs, bone imaging, renal imaging, for all of those. And this is what I was talking about before, the radio opaque barium. For years, we used that for barium enemas, okay, that were there. And that's, so you're trying, because we had to outline the gastrointestinal tract and look for things. I had one of those things done when I was having all these ulcers. I had to have barium swallows, things like that. I think that's everything with that. So there isn't a lot involved with this. Oh my goodness, I'm at the end. Okay. And then this was another PowerPoint that I looked at that was fairly generic about what different uses were. And we covered a lot of this before. I think the shielding becomes very important. Again, this is the same thing that you had looked at before, various kinds of scans that were part of it. And they're just trying to give you an idea with regard to, here again, the technetium-99 and the I-131, where they come from. Most common site intravenous injections. Is that something you've started to do or practice on at this point in time? Yes? No? Not so easy to do. I did. It took me about 2 years of doing it almost every day to be good at it. So I started doing that. The first time I did it was in an emergency room with a burn patient. And these guys came in. There was a big fire. at a flop house. That's effectively a place where homeless individuals go for 50, at that time 50 cents. So a night out in the cold, Christmas night, of course, big fire. We had it became, and you'll become familiar with this. You work in a hospital called a disaster drill. And so all of a sudden, and every doctor's got stories. They all do. It's what you learn when you're a resident, because you're in the hospital more than you're anywhere else. And these people all came in. I had never started an IV, and there was like 5 of us on duty. Nothing happened. And all of a sudden went from absolute boredom and a party to chaos. And we had to start we were putting in wide bore IVs into these people 2 at a time. Not 1 line, but 2 lines. You learn to get good pretty fast. And after doing that for a while, within about 6 months of doing that, between the first and the second year of my residency, I ended up, they had me doing a lot. I used to be called it the radiology to do, to find veins and drug addicts. We had a big drug and alcohol population. We were deep in the inner city in Philadelphia. It was a pretty rough area. I'm sure it's not a whole lot better now. I haven't been there in a while. So again, different kinds of things that go along with it. And they look at the processing and the report. This is the radioimmunoassay. And there's a variety of things that you can look for this. This is a very sophisticated way, I would think, to find low levels of chemicals that are there. Because a lot of these are very, very hard to ascertain without using it. And then obviously the therapeutic aspects, which I'm not that familiar with. All the different types of things that you can do with it. And so here, looking at some of the scans versus normal activity, and you can see the distinction between them. Okay, Graves' disease is a hyperactivity of the thyroid. It's an autoimmune disease. It's highlighted. It produces so much swelling that people, it looks like their eyes are popping out. That's the tell. That's the given. And it produces that. And so Graves' disease, here's something with toxicity. Here's something with a toxic adenoma, which is a tumor. That's part of it. Here are the bone scans, where you can look at what, depending on the age of the individual, you would expect a certain amount of activity. This might be, relatively speaking, normal. Because maybe somebody had an injury to a rib. Most of your production of active bone marrow in an adult is located in what are called flat bones. So those are vertebral bodies, the sternum, the hip area, etc. Here, not like that. Too much going on. Now you're looking at renal activity. What the distinction is, so here you can look at scarring of the renal. So when you have an idea what normal looks like, it's easier to ascertain what normal does not look like. And I think that's always the thing. This is gallbladder activity. And again, in the old days, we used to do different things. We would just inject a substance that would, because the gallbladder accumulates fatty substances, something that you would inject and wait over time. It's called an IVC, or intravenous cholangiogram. Okay. And so really, I think a lot of this, when we start looking at different kinds of disorders with the PET scan that are there. I don't know if I have another one of these. That's the imaging one. And there was a lot that's involved with that as well. I'm going to hold off. I did want to, this is one that I was looking at, and we did this years ago. And I recalled it when I was trying to get organized for this, was this gallium scan. And this is an interesting scan, and I didn't know how it worked. We used to think it would attach itself to white blood cells, so you could monitor for things like infection or acute inflammatory processes. So a very small amount of radioactive gallium has to be done before intravenously. Any cells that are actively dividing, so it could tag cancer cells, someone with an acute infective process, you're going to be producing very, very large amounts of white blood cells, et cetera, that are there. So fever, lung infections, osteomyelitis is a bone infection, so sometimes we would use it for that. Sarcoidosis is an odd situation. We don't know quite a bit as much about it. It's an autoimmune disease, very famous here in Pittsburgh. We had a mayor die of it. If you go over to City Hall, mayor picture of Richard Caligari, who was like into his fourth term as mayor and succumbed because it happens to people who are of Italian heritage. And it was another, and the mayor up in Erie also succumbed to it very, very shortly thereafter. It was kind of interesting. And I think that's everything for now. Like I said, I'm going to get together and put together a case study for you to look at and comment on for Thursday. So thank you. I got to escape from this. Help. Here we go.